we're going to talk about pre and post-transplant rehabilitation. So I just want to start by saying that transplant rehab is a different perspective, especially from the pre-transplant, before someone gets an organ. Typically, when we see patients in a rehabilitation setting in a PT clinic, our patients typically get better. Their condition gets better. They make improvements functionally. Now, with pre-transplant rehab, quite often do patients they don't get better, right? These are critically ill patients. So you're kind of working against the clock. You're working against the natural history of their condition. So it's just a little bit different. Like you're kind of fighting an uphill battle. It's a noble battle, and it's one that will often lead to better outcomes after surgery. But it's a little bit different perspective that it takes a little bit of an adjustment to that. Often you try to constantly progress your patients, and a lot of what you're doing with pre-transplant rehab is trying to preserve as much as you can, and realize that, all right, well, okay, now they can't do this. Well, what can we do to keep them moving? So just a different perspective, especially from the pre-transplant perspective. So pre-transplant, again, chronic disease of any kind leads to muscle weakness. It could be in a hospital for a long period of time, fatigue, bed rest, mobility issues, maybe breathing mechanic issues, right? Inability to clear secretions, right? Or inability just to move around, right? They're just not doing too well. These are critically ill patients, critical heart failure, critical lung disease. So our goals for pre-transplant is to preserve. Again, we might make some improvements. But as the longer they're in a pre-transplant program and waiting to get, a lung transplant or heart transplant or any organ transplant, their condition is, while we're trying to keep them as stable as possible, is going to gradually deteriorate. They're going to get worse. So they may not make improvements. Your goal may just be to maintain and maximize functional performance as long as we can. We've even some of the thought processes is, these pre-transplant programs can really just be a way for us to allow patients to stay listed on a transplant list longer, right? So if we can keep them preserved, keep those muscles functioning as best as we can, keep them active, it may actually allow them to be listed longer to survive this chronic disease as long as they can, to be transplanted eventually. So it's just a different perspective that most people in rehab aren't used to, because usually our patients get better and then they go home and go about their business. For us, someone living with, kind of working against the clock here, right? They've got a condition it's gradually deteriorating. You're working within that. So it's a hard thing. You have to swallow your pride sometimes that your patients may not get quote unquote better, but we're preserving, and that's huge. So our education, we often spend a lot of time talking about that. What are you going to be expected to do post-transplantation? Precautions like teaching them how to effectively roll out of bed, with a sternal incision, how to brace themselves so they can cough and clear their lungs. And pre-transplant rehab, the evidence now is building in this area, has been shown to be beneficial on post-transplant mortality, functional capacity, and quality of life. Because again, if we can kind of improve their muscles and maintain muscle performance, right? Now that we've corrected that central cog, going back to that Whip and Wasserman gas exchange gear, right? So again, looking at our cogs, right? If we can kind of keep that muscle cog as good as we possibly can, now that we've corrected this, they may do even a little bit better, right? Because we've preserved the muscle as much as we can, and we've corrected now one of the main limiting factors was that central disease. So post-transplant rehab, typically the inpatient goal is just going to be like anything else: early mobility, getting them up and moving, the ICU, gait, balance, ADLs, functional mobility, some barriers, acuity of illness, medical and cognitive status. They may be event still, sedated, and just getting patients up and moving sometimes in a critical state can just be a little bit challenging in general. So anything that you would expect typically to be a barrier in ICU rehab is going to be a barrier even if, with a post-transplant. But it's important these patients get up and moving. And again, they may be in the hospital on average 3 to 4 weeks, especially in the United States. So our inpatient goals: improve functional capacity, improve level of independence, progress exercise. And again, like now the post-transplant side, yeah, we're looking at, now that we've corrected this critical disease, we can start thinking about progressing. Our patients may start to improve. So pre-transplant, it's preserve. Post-transplant, let's improve, let's increase, right? Because now we've corrected essentially whatever was going on with that, organ. Education, giving them some guidelines. And there's also some special considerations for exercise we'll get into a little bit later post-transplant. Outpatient phase, typically this is going to be different depending on the facility. Where I'd worked, it was roughly about 3 months after transplant. They were still at our facilities. So our goals, typically we want to see VO2 improve at least 1 MET from baseline within the first 10 weeks, and then 2 METs from baseline after a year. And typically your exercise capacity will plateau within the first year. So we may not make wholesale changes. These are our goals. These are what we may expect. But we should be striving for improvement because we've corrected essential disease. But while acknowledging many of these patients were living with chronic disease for many years, so that we may not see super aggressive improvements, but we should start to see some improvement, right? At least 1 MET after 10 weeks. Upper extremity resistance training for cardiac and lung transplant should be delayed for about 6 weeks. So at least for the first half of the program, they're not going to be doing any external weights just to keep those incisions healed, right? Because we've either done a median sternotomy, a thoracotomy, or a clamshell. We want to make sure those surgical sites stay stable and we don't add another complication to what is already a little bit of a difficult situation to manage post-transplant. And again, motivation, adherence, exercise are the major problems. Like we're finding that, again, we're dealing with a lot of unique things, that happens to patients after transplant. We got to keep people engaged. And the great thing about the VA model where I worked in, these patients would, work in groups. And they're all veterans, so they could commiserate with people, their colleagues, and I think that was always fantastic to see how they bonded together in that setting. And the great thing is too, they stay compliant with exercise. Their quality of life definitely improves, exercise capacity improves, and they may actually help reduce the side effects from some of those immunosuppressants. So if they keep exercising, keep moving, right? It's going to be to their interest. So it's a good key education piece for our patients as well. Now, some key things for heart transplants, post-transplant, obvious external precautions. The big thing is that there's going to be a denervation of the heart, and we'll go over what happens there. The other big one, like we talked about, myopathies and osteoporosis, just be gradual with your progression. In those patients in terms of resistance training and anything that we do, just because there may be issues of myopathy, tendinopathies because of the corticosteroids and immunosuppressants that they're on. Now, post-heart transplant, the heart is denervated, right? We cut basically the sympathetic accelerator nerves. Here's my little guy here. We cut these, and we cut the vagus nerve too. So because of that, there's no neuromediated control of heart rate, right? So typically when we get into exercise, heart rate increases, sympathetic nervous system, or the parasympathetics withdraw, we see a relative gain in sympathetics. And as we continue exercise, we see those sympathetic outbursts kind of increase. That doesn't exist in a patient with a heart transplant. Their drives to increase in heart rate are due to the muscle pump, so from venous return, and from circulating catecholamines, right, which take a little bit longer for heart rate to ramp up. So typically we'll see heart rate increase, or we'll see blood pressure typically increase maybe even before heart rate, and heart rate typically decreases a lot slower. So understanding that their increase in heart rate will be much more gradual, so to gradually ramp these patients up to monitor and to gradually cool them down, and that the responses are going to be different. We can't use normal response, 12 beats per minute, one rest, it's just going to be different for them because they don't have that fast neuro-mediated control of heart rate. So you want to make sure they are given adequate warm-up and adequate cool down just so that we can get the muscle pump going to get the heart rate up at the start of exercise, and that we can gradually ramp them down so that they're not stopping exercise with the heart rates beating super high and there's no more muscle pump causing them to pass out. So gradual warm up, gradual cool down, because the heart rate response is just going to be delayed. Okay, so just be aware of that. And they're going to have typically a higher resting heart rate, 90 to 100 beats, because again, there's no vagus nerve to pump the brakes at at rest. These are all things to be aware of, and they might not have chest pain either because of the denervation. Because again, we've extracted their heart, cut out the neighbor's heart or the donor's heart, and the nerves may not retake. Now, looking at exercise capacity, so 50% of patient exercise capacity, or of patients, their capacity is less than 70% of normal. Only a rare number achieve 90% of their predicted norms. We think this may be due to transition from type 1 to type 2 fibers in patients with heart failure, COPD, because they've just been inactive and all the inflammatory changes that happen to the muscle with chronic conditions. They may be on corticosteroids and immunosuppressive therapy, which is also very deleterious to the nerve, to the muscle, to the bone, to the tendon. So there are all these other peripheral changes, despite the fact that we've had correction or we've improved or we've replaced the diseased organ causing their condition. We have all those changes in the peripheral muscle. So going back to that Whip and Wasserman gas exchange gears that we introduced at the very beginning of the course, those three cogs work together. And if the muscle function is not ideal, right? If we have all these impairments, even though we've replaced the organ, exercise capacity is still going to be limited. So that's really kind of where the medium by which they still have limitations, as well as the medium by which we make improvements in exercise capacity in these patients as well. So again, looking at a plot of patients post-transplant for heart, like we mentioned, walk distance for the lungs. For heart, it's for a normal population. Transplanted patients still like pretty far below. Most patients are going to get for transplants on the average, right? They're going to be around, getting to, the 7 mets, right, or 8 mets capacity, right? They're not. We're not seeing super high amounts. Now, there are some patients that do get, above, normals, right? They get to that 13 mets. Now, I had a patient once who, after lung transplant, was running. He was I think it was about a month after a lung transplant. He was also super healthy prior to his disease, and he had a hypersensitivity pneumonitis. So he had a very aggressive form of a fibrosis. He didn't have all those pathological changes to the muscle because he didn't have the condition that long, and he did very well. I guess so. It's going to be different depending on the age of the patient, what other changes have happened to the muscle, and that's often linked to the type of condition they had. Again, alpha trypsin 1 deficiency, it's a younger population. A patient with hypertrophic cardiomyopathy would be a younger population. Hypersensitivity pneumonitis, typically, they may be an older population, but they don't have the condition that long. So this is a breakdown of the individuals who are their functional status. So anyone above an 80% are able to carry normal activities, without any special need for care. So if you look at the number of individuals, like, even after the first year, 80% are able to do things for the most part on their own. They have pretty good independence, and this is a heart transplant. 70 would be unable to work, but they're able to still do things. So the overwhelming majority of people are pretty functional even after their first 5 years, right? So and anyone below 40%, would be individuals who are unable to care for themselves, and they would basically be institutionalized or have hospital care. And then looking at the individuals who return to work, which is kind of neat. Looking again, that 1 year mark, 3 year mark, 5 year mark, the numbers improve. Again, if you look at the data, like the majority of people after a heart transplant, like are able to carry on normal activity, no special care needed, especially if they get past that first year, and some may even return to work. Now, there are some considerations. Again, a lung transplant I want to bring up. Again, we talked about those changes, oxidative capacity, chest wall deficits from essentially the clam cell procedure. We also may see almost a bronchial hyperresponsiveness, which may be due to a few things. Again, some people think that because these patients have had a protracted respiratory control center because they've had long-standing disease, even though we've corrected the lungs, that any exercise triggers this hyperventilation. So just something to be aware of, that these patients may need just some cues to control their breathing while they're exercising to kind of lower those anxiety levels. That's something I would see all the time after a transplant. And then and there may also just be this hyperresponsiveness too in the airways, even beyond just a mental aspect. So again, looking at patients following lung transplant in terms of outcomes, like I mentioned, lung transplants, they typically, they don't do as well compared to their heart transplant, cousins. But still a large portion, right? Get above that 80% score. So above 65% don't need, special care. And that goes up after the second year and third year, where we're looking at about 70%, right? Or don't need any special care. And then, there are only, there are about a 30% or so that need additional care, occasional assistance, or more. But if we include that 70% score, there's a lot of, people that still can manage on their own. And then even as a pretty large number that are able to manage things on their own and maybe even work. Very, very minor symptoms. And if, again, we look at the percentage, right, there's a number of people that aren't able to go back to work. So at 15% at 1 year, 3 years, goes up a little bit more. And then at 5 years, 20% may be able to go back to work. Now, it depends on the facility, depends on the policy, but that's an option for some patients who, are able to keep vector control and don't have many limitations. Now, in summary here, I think a very kind of promising thing is, like I had mentioned, we do not have enough organs to give everyone who needs a transplant. Just aren't enough. LVADs are great, but they have unique complications, like we talked about in the cardiac section of this course. What is very interesting is now with the onset of 3D printers, we may be able to print hearts using your own cells, which would potentially remove the need for any form of, or at least lower the need for immunosuppressants. So all the secondary complications, the cancers, the infections, other issues, the kidneys, the bones, the tendons, may be mitigated. They may do a lot better. So we're seeing this. It's been done. We've been able to replicate hearts. We'll be able to replicate vasculature. It's just trying to put them all together. And now, we've done this now in a pig model for lungs. I think in maybe the next 10 to 15 years, we may start seeing this used more often. So I've got 2 great citations on there. One by Nora, which looked at printing of a thick and perfusible cardiac patches. So that's an example here. And then a bioengineered lung using a pig model. And again, we start all these things in other animals before transitioning to humans. So I think bioengineering and 3D printing, that's going to be the future of organ transplantation. So guys, I hope you found this stuff to be useful and just interesting. Again, transplant, rehabilitation, and surgery are just very unique subspecialized areas. And if you like working with a medically complex population, like kind of using your brain a lot with care, this is your place. Like if you like to see physiology on display, There's no greater place in the transplant population, and it's a great population to work with. Some of my best memories as a new clinician, we're working with this population. So thank you guys for tuning in, and that will conclude actually our lectures for the semester. Thank you.